everybody, and welcome to episode 52 of CCA's Medical Minute, sponsored by Kroger Health. Episode 52, which does not mean we've been going for a year yet, because you have to think about that. You'd have episode 1 and 2 that would be within 1 week. So we're 1 week short of a year old. But it's coming soon.
Are we having a party? Do we get to wear party hats next week?
I think you can wear whatever you want. We're all pinked up today, as
I know.
everybody can see.
Look at us.
We're all pinked up for breast cancer awareness in October, our second episode of the month dealing with breast cancer.
I feel like we're showing like preferential treatment to the pink ladies. Like, you know, I don't feel like we've. Idea. I mean, don't get me wrong. Breast cancer deserves the respect that it gets.
Yes.
But maybe we should spread the wealth.
I think so.
Yeah.
I mean, I think so.
Every cancer's got its month, so
yeah. Some months have more than one, as we know. So
absolutely.
Anyway, so we'll talk about. We talked to Sherry Hughes last week about her own breast cancer journey, but we thought we would speak a little bit more generically, I think, this week about breast cancer types and then some of the terms that you hear: ER positive, PR positive, that kind of thing. We'll talk about that because and HER2, and isn't there HER2 new? What is HER2 new?
HER2 and HER2 new are the same thing.
Oh, they are. Okay, gotcha. See, there you go.
Well, and then triple negative, that's a big buzzword too. So.
All right. So really when it comes down to the breast cancer types, it's mainly a ductal carcinoma that is either something to worry about or something not to worry about as much, which would be called in situ, correct?
Correct. In situ is less scary, but still scary in its own right.
Can in situ morph into a breast cancer, or is it always kind of just considered to be non-cancerous? Well, or non-invasive, I guess you'd say.
I mean, we call it stage 0 for a reason. Yeah. You know, if it was not cancer, it just wouldn't even be on the scale. We call it stage 0, and even from a genetic standpoint, DCIS equals breast cancer. So if we have, if all your aunts had DCIS, we count those all as breast cancers when we're talking genetics.
And from
Andy, describe what DCIS means.
Oh, yep, that was a medical
term.
Ductal
carcinoma in situ.
Yes.
All right.
Yeah. So it's a non-invasive breast cancer. Think about when you're talking about ductal carcinoma in situ. Think about the duct where the milk is created and goes out out the nipple for the baby. In that lining, that turns into cancer. And if that duct gets full of cancer but stays within the duct, that's a DCIS. Now, the moment it breaks out, you got one cell that breaks out of that duct, now that's invasive cancer.
Okay.
So that's the difference. It's just literally a less than a millimeter of difference there.
Okay.
And it's hard to say, like, if you left a DCIS and you just didn't touch it, what would happen to it? Well, nobody's doing that research. Nobody's going to knowingly leave a cancer in place and leave it alone and not do anything to it.
Okay.
So it's really hard to say, well, how long would it take before it would turn into something invasive? I don't know that anybody really has that answer because nobody's going to take that risk.
But the point is, it's stage 0, but you still treat it?
It's still surgically removed.
And we often, we do test hormone receptors on it. So is it influenced by estrogen, for example? And we'll treat it with anti-hormone therapy, anti-estrogen therapy.
All right. Good segue into the next part.
Look at us go.
I know, which is that, and this is maybe for selfish reasons because I always struggle to kind of understand what these terms mean, but let's talk about ER positive and what ER positive means. So before we talked about types of breast cancer. Now this is really more.
So when someone is diagnosed with breast cancer and they've removed the cancer and that tissue goes to pathology, as soon as they confirm that it is a breast cancer, the very first thing that they do is they test for estrogen, they test for progesterone, and then they test for HER2.
Okay.
Those are the three things that it's a reflex. As soon as you know, they're checking for those things. And the reason for it is because there's treatments associated with those results.
Okay.
But it is on the actual cancer tissue that those results come from.
Are there any times that, let's say, for example, someone is either ER positive or PR positive? Can you be both?
Usually you are.
Usually
you're
are.
not.
Okay.
You are not typically PR positive, but not ER positive.
Okay.
It's usually ER/PR positive or ER/PR negative.
Okay. So let's say, for example, you have an invasive carcinoma and you're ER and PR positive. Do you get hormone treatment in addition to, say, for example, chemo and radiation, or is it
For sure. We actually think about it the other way. We always are, anyone who's estrogen and progesterone receptor positive, we're giving those people anti-estrogen therapy. And then, geez, are we going to give chemo before that? Or that's always going to be the base therapy for that kind of cancer.
Okay, so the hormone therapy is the no-brainer part if you're ER and PR positive.
Correct.
Okay.
Yep.
Gotcha. And then, so how about HER2? What is HER2? Is it a protein?
I'll let you take this one.
I always tell patients that HER2 is, it's like a on switch for the breast cancer. And we usually had previously thought of HER2 as being, it's a yes or no question. Are you this or you're not? And it almost implies that you have no HER2 or you have a ton of HER2.
Okay.
But we've known for a long time that there are degrees of HER2 that's present on breast cancer cells. And in fact, again, it wasn't until more recently where we actually started beginning to think, okay, there's HER2 negative, there's HER2 positive, but there were these folks who, when they did a special type of testing called IHC testing, immunohistochemically testing, that's a lot of syllables. Very doctor. Right. Sorry.
But you at least said what it was.
Yes. So IHC, and if you scored 1+ or 2+, those might actually eventually be termed, 1+ is always called negative. 2+, they would, they would run what they call a FISH test on it. So a specific genetic test on that to see, if they were going to call it positive. But now we're calling those 1+, 2+ HER2 low. Okay. The reason for that, as we talked about with the hormone receptors, is that there's now a treatment associated with that, and so we have to know that, and so you should that percentage that is HER2 negative is actually a small percentage now. 50 to 60% of people are this HER2 low, and now there's a viable treatment for that.
Okay, and then so let's say, for example, so you're ER positive, PR positive, maybe both. And then so now I can get a hormone treatment. But let's talk about triple negative. So triple negative, which my wife was triple negative breast cancer. So that basically means I'm ER negative, I'm PR negative, I'm what else negative?
HER2 negative.
HER2 negative, okay. And so what that basically means is there's no evidence that hormones are firing or fueling my cancer in any way,
and
right?
that's where people don't quite understand the concept. So when you're dealing with female breast tissue, normal hormones that you're going to find in normal, healthy breast tissue, you're going to find estrogen, you're going to find progesterone. And so when you have a tumor that's removed that shows no signs of that anywhere, it's looking less and less like the normal healthy tissue, which gives it more of a malignant, more of a aggressive look, because it's so far away from what the tissue originally started as.
So the lack of those receptors can be indicative of
a little bit more. Patients that are triple negative, we watch a little bit closer, because having a triple negative breast cancer has the same risk as a patient that has hormone receptor positive but has positive lymph node involvement. So it's got the same risk. So without having the node positivity.
Yeah, and because you're taking away that hormone pill. Remember I said that was the first thing that we were going to give people, and then maybe we add chemo to it. When you take that away, what are you left with? Chemotherapy. So you are stuck with that normal chemotherapy. So we are giving people with much smaller cancers, much more toxic regimens, because the other ones aren't an option. Another thing about these triple negatives is that those folks are more likely to have a genetic cause of their cancer as well. So that you're going to see more of those be due to, for example, like BRCA1 or BRCA2 mutations, or other mutations are more likely to be triple negative.
So what's interesting to me about this, correct me if I'm wrong, but this would almost be, let's say, for example, if I were triple negative, this would almost be like my prostate cancer journey if I was never hormone sensitive. So
Correct.
It would be like you would just take those drugs away from me. I would have never had them.
Correct.
Which my outcome would not be as good. correct?
Correct.
Okay.
And if you think about it, your prostate cancer patients who are castrate resistant
Yeah.
is the term that they
Yep.
use in prostate. Once they're resistant, it's a little bit harder to
Yeah.
treat
Yep.
because it's no longer responding to the blocking of that
Okay.
hormone. So if like in breast cancer, when you don't have that hormone to block, and you have to think, like for our patients that are ERPR positive, we talk about that we lead, that the foundation is that hormone, the anti-estrogen drugs, and then we layer in the chemo. But once the chemo's done, they stay on those drugs for a minimum of 5 years.
Yeah. Okay.
And that's usually 5 years of kind of protection
yeah.
that they're suppressing that estrogen so that the cancer doesn't potentially come back.
Yep.
So when you take that protection away or the ability to offer it,
Yeah.
you do the chemo and then you wait.
Okay.
And you hope that with what you did with the chemo was enough to kill off every last cell.
Yep. So, I mean, from a practical standpoint, if you're triple negative, you got one less tool in the toolkit.
Correct.
Basically. Okay.
Correct.
Gotcha. Well, then that's helpful. I think we'll touch on a couple other breast cancer topics over the course of the month. Hopefully, we'll get our new Dr. Zahn on at some point in time.
Yes.
We hope to do that before the month ends. So thanks everybody for joining us for episode 52. Next week will be our 1 year anniversary.
Party hats.
Party hats. All right. Sounds good. All right. Thanks everybody for joining us.
Will there be a cake? You know how
We
like
can
when
do
you
that.
have your wedding cake at the 1 year?
Oh yeah.
You know, you eat the one out of the freezer that's horribly
we
like
should have put that
frosted.
in there. We should have put it in on day one though.
I know.
We missed that opportunity. But anyway. All right. Sounds good. Well, everybody, please come back and join us next week. Tell your friends and bring your family, and we'll see you next Wednesday at noon. Thanks, everybody.